Viewer discretion is advised. Some slides may have visual effects that aren't always suitable for all audiences. We use the Emergency Medical Responder First on Scene for our Emergency Medical Responder course. We do not get paid to use this book, however, over the years, this course has been the easiest for our students to comprehend, therefore is why we utilize it. This work is protected by the United States copyright laws and is provided solely for the use of our instructors to teach courses and assess the student learning process. The content on this website has been made available for our instructors to copy and distribute to our students in classes as we see necessary. All education provided is a guideline to help you learn new concepts to better treat your patients. Your local protocol supersedes any education you learn in this course. You must always review with your medical director before changing your treatment plans that are outside of your local protocols. Caring for cardiac emergencies. Review cardiovascular anatomy and physiology. Define the following terms: angina, cardiac compromise, conduction pathway, heart failure, and myocardial infarction. Describe the normal flow of blood through the heart, explain common causes of cardiac compromise, and describe the signals and symptoms of a patient experiencing cardiac compromise. Differentiate and explain the pathophysiology of angina, myocardial infarction, and heart failure. Explain the appropriate assessment and care for a patient experiencing cardiac compromise. Demonstrate the ability to appropriately assess and care for a patient experiencing cardiac compromise. Value the importance of caring for all patients with chest pain as though it were cardiac compromise. In this section, we're going to talk about normal heart function. Normal heart function. The heart beats 100,000 times per day. 6,000 to 7,500 liters of blood circulate the body each day. To put it into perspective, that's about 2,000 gallons or the size of most tanker trucks. The heart muscle receives its blood supply from the coronary arteries. Blockage in an artery results in decreased blood flow to the heart. So think about it this way. If you've got a garden hose and you block part of that garden hose, that increases that water pressure. And in a similar way, blocked vessels contribute to that high blood pressure, which is a risk factor for heart attack and stroke. All right, during the cardiac cycle, the blood flows from the body into the right atrium, down into the right ventricle, and then into the lungs. The blood exits the lungs and enters the left atrium, then flows into the left ventricle. Once that blood exits the left ventricle, it flows out of the body, and then the cycle begins again. I think I've mentioned this before, but there is a YouTube video. It's called Pumps the Blood. It's kind of an annoying song, but at least it'll give you the idea of how that whole thing works. So take a look at that and see if that will help you understand how that cardiac cycle goes. Here's the major anatomy of the heart, which includes the blood flow through the chambers. This will also be in your bookwork. The conduction pathway is the core of the electrical system that keeps the heart beating and the cardiac cycle going. Damage to the conduction pathway can lead to an abnormal heart rhythm and is a common cause of poor circulation and perfusion. So think about this. When electrical messages are interrupted, performance is affected. It's similar to when the digital picture on a TV is distorted or when a storm comes through and causes signal interference. It's essentially what's happening in the heart as well. In this slide, the heart conduction pathway is highlighted in the green. So as you can see, all of those green highlight areas, that is the conduction pathway. On this slide, you can see the heart muscles again, the right coronary, left coronary, and the anterior descending branch. So remember that the coronary arteries supply blood to the heart muscle, okay? Also known as the myocardium. The heart is a muscle with a big job to do. Problems can arise that affect the heart tissue and or the electrical system. So think about some problems or name some problems that can affect the heart negatively. Keep this in mind so that when Skills Day comes around, we can discuss this and talk about it in class. In this next section, we're going to talk about cardiac compromise. So the first thing that I want you guys to think about is what is cardiac compromise, okay? So think about that when we're going through these symptoms. So during cardiac compromise, some symptoms that your patient might feel is chest discomfort, diaphoresis, dyspnea, nausea and vomiting, anxiety or irritability, abnormal pulse, abnormal blood pressure, and the feeling of impending doom. Next one we're going to talk about is angina pectoris. So angina is pain in the chest. It is decreased oxygenated blood supply in the coronary arteries, which leads to an increased oxygenated blood demand in the heart muscle with exertion, partial blockage, spasms, and so forth. So how can you tell if that patient is experiencing acute angina or if they're having a heart attack? Well, unfortunately, there's no way to know necessarily in the field, and a diagnosis can actually be made pre-hospitally between angina and a heart attack. So you can give them their aspirin, give them their nitro, give them oxygen, and so forth. But these patients should all be transported to a hospital for the actual diagnosis and then the further follow-up treatment. Signs and symptoms of angina are nearly identical to a heart attack. However, there's no actual damage to the heart muscle with angina. So patients with angina history typically carry nitro. Treatments for the angina and the myocardial infarction or heart attack are the exact same thing. Okay, oxygen, aspirin, nitro. If you're an ALS service, pain medication. Difference is that angina is triggered by exertion and is often resolved with rest, whereas myocardial infarction symptoms will not resolve with rest. So the EMRs should never cancel the responding EMS agency if the patient claims that there's any relief. Make sure that that you let that EMS agency get there. They do a 12 lead, they check them all out. If they're still relieved, fine and dandy. If not, then they need to go in. The next one we're going to talk about is myocardial infarction. It's also known as an MI or heart attack. Myocardial infarction, when you break the word down, so myo is muscle, cardial is heart, and infarction is tissue death. So it is caused by the blockage or narrowing of the coronary arteries, which leads to a permanent decrease in oxygenated blood supply. And without that oxygenated blood, the tissues of the heart will actually begin to die. So how effective will that heart muscle be if any of the tissue begins to die? Okay, something to think about. So overall, the heart's effectiveness will then be just diminished. Okay. Typical signs and symptoms are pain, pressure, tightness, or heaviness to the chest or upper abdomen area, pain or discomfort behind the sternum, pain radiating to the shoulders or the arms, and pain to the back, neck, jaw, or upper abdomen area. So what should immediately be done for these victims of cardiac arrest? CPR and AED. Okay, get that on them right away. Atypical signs and symptoms can be like flu-like symptoms, such as nausea and vomiting. They might have indigestion or feeling of general weakness all over. Normally, elderly people, diabetics, and women are most likely the candidates for these atypical symptoms. Large amounts of tissue death or damage over an important electrical pathway may lead to cardiac arrest. Patients in cardiac arrest are unresponsive, not breathing, and have no pulse. It is key to get good quality CPR going and get that AED on them as soon as possible. In this figure, it's distinguishing the difference between angina pectoris and myocardial infarction, and as you can see, most of them are very similar, if not the same. So think about it from this standpoint, is that both myocardial infarction and angina can present with symptoms of chest pain. So you're going to treat all cases of chest pain as a true cardiac emergency. The next one we're going to talk about is congestive heart failure, or CHF. Weakened heart muscle is unable to pump blood efficiently and manage normal blood volume. It's chronic due to the cardiac diseases, and it can be sudden after myocardial infarction. With congestive heart failure, fluid backs up within the circulatory system, causing issues for the lungs and lower extremities. Signs and symptoms of heart failure include shortness of breath, chest pain or discomfort, rapid pulse rate, pedal edema or swollen ankles, jugular vein distension, also known as JVD, pale, moist skin, and altered mental status. Patients with shortness of breath may have difficulty speaking and answering questions. So think about this. Why do people experiencing shortness of breath usually prefer to sit in an upright position? It's because an upright position is easier and better to breathe in. In this figure, you're going to see signs of heart failure, including in picture A, where it's got the bulging neck veins, and in B, the edema of the lower extremities. So here's something to think about with cardiac compromise. Cardiac compromise is a life-threatening condition. So a question they ask is, why is it important to rapidly identify cardiac compromise? Well, rapid identification and subsequent treatment will help minimize that heart damage, which is very important. And then describe the difference between angina and an MI. Well, remember we talked about earlier that the signs and symptoms may not differ greatly, but transport to the hospital for definitive diagnosis and treatment is key. So you want to be sure to get these patients in. In the next section here, we're going to talk about emergency care for cardiac compromise. So for some emergency care, you want to make sure you always take appropriate standard precautions, perform a primary assessment, and support the ABCs as necessary. If allowed, you're going to provide oxygen per your protocols, and the SpO2 should be between 95 and 100% for your reading. So why might it be beneficial to obtain a medical history from a family member on scene rather than asking the patient with shortness of breath to respond? Well, patients with shortness of breath often have difficulty speaking in full sentences and talking because they just don't have enough air. So it might be easier to get more information out of the family than out of that patient. But remember, we always want to try to ask patients first because they're the best historians for themselves normally. To determine the chief complaint, you're going to ask them the onset, the provocation, quality, region and radiation or radiates, severity, and time. Okay, so we talked about this, the OPQRST. So the onset is when it happened. Provocates or provocation is, does anything provoke it? Does anything make it better or worse? The quality of pain, is it dull? Is it sharp? Is it stabbing? Is it pressure? Then the region of the body, so is it in the chest? Is it in the abdomen? Does it go anywhere else? And then the radiate is, does it go anywhere else? The severity, on a pain scale of 1 to 10, 10 being the worst pain they've ever felt, where do you put that pain at? And then the time again, okay? In this figure, it's an algorithm for the emergency care of a patient with signs and symptoms of cardiac compromise. So if they're having chest pain, is the primary assessment okay to do? If it is, then you move on to your secondary assessment, determine your priority, and then reassess. If it's not okay, if that primary assessment turns up not okay, then you're going to provide BLS care. During your emergency care, you're going to provide emotional support and reassure that patient. You're going to allow the patient to maintain a position of comfort, usually in a sitting up position, and then obtain that set of vital signs. So why is it important to ensure the patient does not exert him or herself during a cardiac compromise? Well, it's because the heart tissue may be dying, and any exertion such as walking can actually compromise that heart's performance even further. In this figure, it is showing an algorithm for assessment of patients with chest pain. So if you have a patient that complains of chest pain, you're going to put them in the position of comfort, keep the patient at rest, and reassure them. If the patient has any medications, then you're going to assist with the medications if appropriate, and then reassess. If they don't have any medications, you're going to monitor their ABCs and vital signs. Next, you're going to assist the patient with prescribed dose of nitroglycerin if your protocols permit of doing so, or consult your medical direction, and then continue to monitor their vital signs. As far as medications, nitroglycerin can come in tablets, sprays, or paste. It's prescribed for angina or previous MIs. It dilates the blood vessels, which decreases the blood pressure and reduces cardiac workload. It can cause dizziness and feeling lightheaded are the most common side effects. And you're going to assist the patient according to your local protocols. It is still helpful to ask the patient if he or she has taken nitro or aspirin, even if your protocols don't allow you to assist with that administration. but the information gathered should be relayed to the EMS responders when they arrive, just so that they know that they've already taken some. Not that you can't give them anymore, but at least then they know that they've at least had one round of it. Here's your different types of nitro. You got the spray, the tablets, those really small bottle or the larger bottle. They're all 0.4 milligrams. Even on the sprays, one spray is a 0.4 milligram. Here is your bottle of aspirin or ASA. As you can tell, it's 81 milligrams, so that you would need 4 of them to equal the 324 milligram dose that's required. Okay, aspirin, which is an analgesic, a clot inhibitor. It's prescribed daily for angina and is beneficial for patients exhibiting signs and symptoms of an MI. You can assist the patient according to your local protocols with this. Again, it's 324 milligrams is the dose. So on that Bayer aspirin on the slide before, that was an 81 milligram per tablet, so you'd need 4 of those, and they can chew them right up. All right, for cardiac compromise, here's something to think about. What does time is muscle mean? Okay, so essentially what it means is the faster that you can treat a patient in cardiac compromise, the less any heart muscle is at risk of dying and or suffering any permanent damage. So performing a thorough assessment and appropriate treatment can contribute to how well the patient recovers from cardiac compromise. You guys, as medical responders, can and do make a difference. And here's your summary. A properly functioning heart is at the core of a healthy cardiovascular system. Blood flows through the heart in a precise way. Each heartbeat is generated by an electrical impulse that flows along the cardiac conduction pathway. When normal heart function is disrupted, the patient will display signs and symptoms of cardiac compromise. Signs and symptoms of cardiac compromise include chest or discomfort, possibly radiating to the shoulders, arms, neck, or jaw. Shortness of breath, pale, moist skin, nausea, and weakness. Angina caused by insufficient supply of oxygenated blood to the myocardium. Myocardial infarction occurs when a portion of the myocardium dies due to inadequate blood supply. Congestive heart failure, or CHF, is caused by a weakened heart that can no longer pump the blood efficiently. Care for cardiac compromise includes the ABCs, airway, breathing, circulation, supplemental oxygen, obtaining a thorough medical history, and monitoring vital signs. Initiate ALS transport if available. If you have any questions, comments, or notice something that needs to be changed, please reach out to us at lakescountryedu@gmail.com.